Hello, and thanks everybody. This webinar is also going to be recorded and available later. So for that audience, as well as the current audience, if you have questions that we just couldn't get to, go ahead and email us. And my email address is at the end of my slide set here. Okay, so this slide shows the various strategies that have been shown to work in tobacco control. And as you can see, I've highlighted the three on the right: the availability of treatment, and we have the availability for treatment. We have the state quit line, we have providers, we have medications. You just heard a lot of the details for such things. Let me skip to the last one there, telephone counseling and support, and that's the quit line, and the state of New York has one of the best, arguably, in the world. Now look at the one that's bold there, provider reminder systems. So before electronic health records, we had a green checklist that our team used to give out, but any kind of a chart reminder or alert is what we had back in the day. Now with electronic health records, obviously, this is where we need to go to make this truly be cooking with gas. Okay, you've heard some of this before, but most smokers do want to quit and have made a serious quit attempt recently. And even 1 to 3 minutes of advice from a clinician is effective. So even clinicians who truly do not have time to get to their patients, if they could just do that strong advice for 1 minute, that makes a huge difference. But look at the rest of this slide. More counseling is obviously more effective. So if you add that 1 minute that a clinician does, have the other providers and professionals in the office trained to continue the conversation, then provide them access to the state quit line and state website, that conversation is extended to something like 30 minutes or more, and that's where the evidence really starts to kick in, and we're making a difference. You've heard about the 5A model, ask, advise, and act, or ask, advise, and assist, etc. That's truly how we want the electronic health records to be modeled. Screening them, advising them, and counseling them when there's time, and making the most of that, and then assisting them with medication and other strategies. You've heard about our Center for Tobacco-Free Finger Lakes. Previously, we were known as GRATSI, and we have learned that with our new model of doing a train the trainer and having entire health systems and mental health systems change, it's this electronic referral system that's really one of our key large goals to get the most bang for our buck, because it'll make the biggest public health impact. As we do everything else we're doing, this has been something we've been working on for a while. So here's a graph depicting how the electronic medical record can work. On the left, you can see the computer screen, the patient record in an electronic medical record to send the referral form or send referral information and receive feedback reports back. Now skip all the way over to the right, and you can see the quit line counselors do their thing. They talk to the person who calls in, call them back, follow up, etc. And they send feedback reports back to the provider. Now there's all that stuff in the middle. And that's kind of where the devil is in the details, and how difficult it's been to have all those things working correctly until we can be cooking with gas and sending referrals out and getting disposition data back. What happened to that person? Did they quit smoking? Did they get 2 weeks of nicotine patch, etc.? So what have we done so far at URMC? And we have a 9-county catchment area. So the Center for Tobacco-Free Finger Lakes isn't just working with our Rochester Regional or with URMC. We're working with all large medical and mental health systems, but obviously we're here, so we're in lots of conversations. So what have we done here? How has URMC done? Well, we do have a comprehensive policy that says we should be using the opt-to-quit. At the state level, we have recommended the minimal data set for all electronic health records. If you can only ask 5 questions, here's the 5 questions you should ask, or the 5 things you should be documenting in an electronic health record. And then along with that minimal data set, we have lots of other items so that those systems who want to ask other questions should ask it that way. So we can compare apples to apples across systems. Otherwise, every system will invent their own way of documenting and asking for these things, and it's hard to compare such things as prevalence rates, cessation rates, etc. Here we've established a refer to quit, and you heard Jim mention the differences. We hope to get to an opt-out model in the future, but for now, having the refer to quit, that capability has been established in the summer of 2017. We've also developed clinical training toolkit on our website, and that has lots of materials for people to use either at the system level or the provider can access those and download them, training materials, patient handouts, physician resources, etc. So these are all steps that are available to help a large system like URMC move forward. Here's an example of ambulatory order set details, so that when the announcement went out that there was this new capability, here's what you say to patients, and here's how you do the referral using the order set that's now been created. So we want these kinds of materials that are also available on our website as part of the training and maintenance of this behavioral change. So there were 3 silos that needed to be collaborated with: the medical, technical, and financial. So we needed buy-in and at least awareness, and passive buy-in or active buy-in from folks at the very top, the technical people, including the actual programmers or builders, who's implementing this, making sure the regulatory and legal issues are taken care of. And then in financial, who will pay for the build? And in some settings, if this type of a build for tobacco dependence is considered another clinical issue that needs to be competently dealt with, there may not be a need for outside finances, because that's just how we do things with an electronic health record. It has to meet certain guidelines, so tobacco shouldn't be special. Medical directors and clinicians involved from the top down obviously are needed, so that when we work with everyone in between, this build or the software programming is known about and approved and supported. Our goal is to make this electronic referral easier, not harder. New building, new programming needs to benefit the medical system financially also. So a strong case can be made for why this is beneficial for reducing hospital admissions and readmissions. That's a DSRIP measure, for example. Saving on healthcare costs, etc. Not to mention the health of the patient, but there's a strong case for the financial reasons for doing this. Here's a terrific quote from a local physician recommending that for something like this, we should eliminate the number of clicks. It's too many. Compare that to going to Amazon. In 3 clicks, I bought a book, and that's a fair point. We want to make it easy and evidence-based and fast. Here's some of the other comments and barriers, and I'll get to most of these in the next few slides. When thinking about HIPAA, will the transmission of data violate any possible HIPAA rules? And that's addressed because the state quit line, which receives data this way, they are HIPAA protected, and we have the steps in place to make sure that all the data transmission will meet those requirements. The actual processes for transmitting the data, that not everyone listening to my voice now knows what some of that real deep programming involves, but finding the right people who do is important. Data security and policies, in addition to HIPAA, to make sure that the data are secured and not able to be co-opted. Legally, one of the issues we learned about was a business associate agreement, and at least having that need or possible need addressed and have the right people say yes or no, you do need this, and then following up with that. Okay, now I'd like to introduce this model called the technology acceptance model. And this is something that I worked with our local, in our pediatric department, Dr. McConaughey, and one of the pediatric postdocs a few years ago, who was also getting her MPH in our department, and it involved assessing caregiver preferences regarding personal health records. And we use this model as a backboard to think about how we're conceptualizing this. And as I'll show, I think this is a good way for us to conceptualize how an institution makes a behavior change. So you can see on this slide, I've mapped the stages of change. You heard about this earlier from Patty. You can see the pre-contemplation or contemplation stages, moving on to preparation, and then actually doing this, the action and maintenance phase. So so we need to ask ourselves, what are the decision-making variables representing the pros and cons of changing at the institutional level, moving along these stages of change to be doing an actual behavior change with a new technology? Just as we would do with patients in pre-contemplation, they don't want to quit smoking. Well, we aid them by educating them, providing them with information they ask us for, that they're open to, finding out where they're at, finding their motivation, making it easy for them for behavior change. Well, the same can be said for institutions. So starting from the right, the actual use. How do we know what's actually being used? We need to have an ongoing evaluation, which is vital to ongoing decision-making, but back when we're trying to develop, implement, and make improvements. Physicians have been referring patients to the Stay Quit line in a variety of ways for 10 or 15 years, but not using this electronic referral system. So where are they now? What do they need to do to get to the actual use using the new tool? So we need to ask them, have you used eRecord before? Which of the referral order features have you used? What's the main way you access the referral orders? So if we keep asking that going forward, we'll see if there are any new barriers we need to address for others who are in this system. Addressing some of these barriers. If you, talking to a clinician, have not used the electronic referral, what are the main reasons you haven't used that? Well, we could ask the institution the same thing. If you as an institution have not created electronic referral, what are the main reasons? We can ask the clinicians their intentions, and they can say, you know, how strongly do they agree with this statement? I intend to use electronic referral more frequently in the future. This is something we'll be asking going forward because they may know about it, they may have used it once. What's their behavioral intention? What influences that? Education, awareness, etc. Looking at the process management and currently how things are documented, etc., and having a real change involves finding out how everyone feels about the perceived usefulness. What are their attitudes towards using this type of electronic referral for tobacco dependence? What's their perceived ease of use? So how strongly do people agree with, I find the electronic referral easy to use? That's something we can be measuring going forward. We can ask them more specifically, how useful is it for treating dependence on nicotine amongst their patients? How useful do they think it is for preventing cardiovascular disease, for preventing cancer and other diseases, etc.? And then how useful is it for overall care of their patients? Because we know that tobacco use can affect all systems of the body. So how much awareness needs to be raised on some of those issues? And then there are all kinds of external variables, workflows, etc. So we can ask, when you have concerns about patient tobacco use, how do you proceed in your setting? So even in a large healthcare system like URMC, there's specific clinics that might do things differently. So that level is going to affect how they use the proposed and current electronic referral. What about getting the specific information they need in order to use this? How easy is it? And we want that answer to be that it's easier and easier as time goes on. Some of the barriers, and these are some of the barriers we've heard. If you as an institution have not created electronic referral, what are the main reasons? And we've heard this in various ways over the past several years. It's not a priority. No one gets reimbursed, the system or the providers. There's no policy requiring this. Patients don't want this. It's up to the patients. Well, there's going to be a cost for programming if this is a new build that needs to happen. And there are legal barriers to forwarding someone's personal information to an outside system. So here's how we've addressed those specific things. Not a priority, obviously, and I'm probably preaching to the choir, we think it's a priority, but so does the Joint Commission, so does several bodies related to cardiovascular disease and DISRIP in various parts of our catchment area. So it's becoming more and more of a priority. As far as not getting reimbursed, it's increasingly being reimbursed in various settings and via various insurance strategies, et cetera. Ideally, someday, of course, it'll be strongly available, that there will be reimbursement. The policy issue has been addressed here. Policy 10.03 has been in place since 2013. Patients don't want this. Actually, they do. 70% of smoking patients expect this from their physicians. Even if they make a sour face or they're not ready to quit, they're in pre-contemplation, but they expect it. And research has shown that it actually increases rapport on a patient population level. Maybe not a certain patient who it could destroy the rapport, but overall, more patients, it increases their rapport. So that's a pretty good evidence to follow up on. The programming cost, if other diseases have lacked outside funding to make electronic health records address them properly, maybe tobacco doesn't need outside funding. But indeed, when there can be outside funding, if that helps grease the wheels, we're on the lookout for that. And then a pervasive myth is that it's up to the patients. It's a behavioral issue. It's a habit. It's up to them when they want to quit, not anyone else, even a physician. Well, in addition to what Patty said earlier about motivational interviewing strategies, I think we all need to keep in mind that this is actually an addiction, and an addiction is a chronic disease, and we need to treat it as such. They need treatment whether they want it or not, and whether there's a habit part of it or not. It's still a disease. We can meet the patients where they are and work with them, but not give up on them. So as with patients who are in pre-contemplation, we need to aid the institution for their decision-making process with education, meeting them where they're at, finding their motivation, and making it easy for their behavioral change at an institutional level. So where are we at? We have a policy in place. It's very clear. Address tobacco dependence with each patient at every visit. Use opt-to-quit. The legal barriers have been addressed. I believe we didn't need a business partner agreement, but both the quit line and our institution vetted that and came to that decision. So another setting may need that, but it's still not rocket science. It's kind of like a memorandum of understanding, and it can be resolved. The programming is finished for the basic referral to the quit line. And currently we've got about, what would you say, Jason, 30 people per month being referred. It went down a bit in...
A little over 100 total in the last 4 months.
100 total in the last 4 months. That's a start. And we need to increase on that. And with our follow-up evaluation, we'll help find out what some of the barriers are and try to make that work better. The disposition data workflow is still in development. When we send someone to the quit line and the quit line works with them, what happened to that patient? They send us back aggregate reports now, and we have someone on board in our center who vets that, but eventually we want it to be seamless and electronic, where the disposition data goes right back into the patient chart. So far we've had one announcement by the PR department, so we look forward to maybe some other pushes around specific events or progress with how the electronic referral is going. So since our uptake is still similar to where it was at baseline, maybe it's the same champions who are using electronic referral that would have done it anyway or been doing it all along. So we need to expand the adopters. Some of the lessons learned. Our center and the Center for Community Health have helped facilitate progress in a variety of ways at the policy level, getting high-level buy-in, this initial programming that's now in place. But maybe each mid-level system is at their own stage of change. And so even though the top folks are now in the action phase, what about people that are in the programming area or the legal area? Do they have the same level of buy-in and preparedness to make their change, to help the overall institution make the changes? So for our team, it necessitates multiple engagement and explaining this and feeling people out at all different levels. Our education throughout an entire system, how is that accomplished? And the other systems we've worked with, and each system, if they have an educational plan, how can we be a part of that rather than inventing something new? How do we find their motivation? Overall progress is only as strong as its weakest link. So if we have the top people buying in, as they have, the clinical council and others, and the programmers now, and public relations, what are some of the other reasons that are not getting the word out and having the clinicians actually using this? Where is there a breakdown? And it's hard to determine this in a huge system, let alone huge systems throughout a 9-county catchment area. The evidence base and the data do not reliably influence decision-making as much as we think it would. Saying that tobacco use is an addiction, showing how other systems have done this, their results, how the numbers have changed. It's hard to convince everyone throughout a system of this and have them buy into it. What might be some of the barriers to that? Is it truly as dismal as some folks think that public health isn't real science or real medicine, and this is not a true evidence base that we're citing? Is it because what I mentioned earlier, that it's the patient behavior, not really an addiction or a chronic disease? Is it truly that there are too many other more important priorities? And there could be. They moved to ICD-10, for example, and that required every programmer's time for like 6 months. So there are other priorities in various stages of this, and that's fair enough, but we want to be at the table and be one of the priorities. So what's our next steps? Increase public relations, messaging, and let people know that this referral exists. The order set is there, where to find it, how to find it more easily. Keep working to make progress with the disposition data. Who can take over for our team to receive data from the state quit line and parse the information to each clinical area, at least, if not the provider themselves, until we have it all done seamlessly and electronically. Evaluation. We'll be sending out REDCap surveys to get feedback and do some key informant interviews to find out what are some barriers to try to help the entire system move forward. What are our expected results? Clinicians who've already used the electronic referral will be more likely to have favorable opinions about its usefulness and functionality. So we hope to hear that, we expect to hear that, but we want to hear from people for whom it's not working and try to address those barriers. These champions will also be more likely to report high intentions to use in the future. What about those who are newbies or new adopters? What are their intentions like, and how can we motivate that to be higher? So we anticipate low to moderate uptake as we're seeing now, but we expect to see steady increases over time with some of the things I've talked about, including word of mouth. As clinicians use this more and more and see responses from their patient populations, that will help sell this. And whether or not some people buy into the data, we need to have data, and data, because data are important to back up our evidence-based approaches. Here's some additional resources. There's the New York State Quit Line. Nationally, there's smokefree.gov. Talktoyourpatients.org is terrific clinician resources. The Surgeon General website. And then our new website is urmc.smokingresearch.edu. Please email me with any questions. And there's actually Tom's email, but email us with questions. And you can find me by Googling my name as well. Okay.